systematic way that we use now to identify, to localize, and then to document the endometric lesions or tissue that we see or that is found. So what are the objectives of endometrial mapping? So in this presentation, we are supposed to determine the disease extent, to identify bowel involvement. Is bowel involved or not? Detect bladder involvement, assess ovarian disease, evaluate adhesions, and assist surgical planning. So the compartments that are supposed to be evaluated when doing an endometriosis mapping are the anterior compartment, which is the bladder, and the vesical uterine pouch. Then you also have to assess the middle compartment, that is the uterus, the ovaries, and the fallopian tubes, if they are also involved with their endometriotic lesions, which are also there. So in the posterior compartment, you have what is called the uterosacral ligaments. You must check on those. Then you have to have the posterior vaginal fornix. You have to check for deep infiltrating lesions. Then the rectal vaginal septum, you also have to check on that. Then the rectum itself, you have to look around it. And then the rectal sigmoid colon, then the sigmoid colon. You have to assess for any deep infiltrating endometriotic tissue that you can find there. So now let's talk about the patient preparation in endometriosis mapping. So the preparation, explain the examination to the patient. That's the fundamental and the first thing that you're supposed to do. Don't do things nicodemously when the patients are not aware what is being done to them. So obtain informed consent from the patient, encourage bladder emptying, then position patient in the lithotomy position. That's the transvaginal that we're talking about, the transvaginal approach. So use a high frequency transvaginal probe, 5 to 9 megahertz or higher. Then perform a gentle examination due to tenderness. So you know these patients, some of them they will be feeling tenderness due to the endometriosis. So you must also use a gentle examination. So the clinical history of the patient. Ask about the dysmenorrhea, dyspareunia, chronic pelvic pain, dyschezia, dysuria, infertility, or previous surgery. So you have to ask that kind of history or capture that history before and during the examination. So the idea examination protocol. So here is the protocol. So there are basically 4-step idea protocols, that steps that you are supposed to do when you are doing the idea protocol. So the first step for this protocol is you have to check the uterus and the ovaries. Uterus and the ovaries. Then the second step, soft markers, site-specific tenderness, ovarian mobility. You see that? The second step of the protocol, idea examination protocol, is you have to check for markers. Are there any obvious markers of endometriosis? Site-specific tenderness, go there where the patient is saying that this is where the pain is. Then ovarian mobility, check if the ovaries are moving. So the step 3 is a sliding sign. So the ovary has to be to move. The uterus, sorry, it has to move. That is what we call the sliding sign. I will demonstrate that practically. I will check a case for you, then I will demonstrate for that. I'll present on a practical case like that. Then you can see the sliding sign, how it is done, and where it is positive and negative. Step 4, deep infiltrating lesions. Stress using the same sequence in every patient for consistent. So you must check for deep infiltrating lesions. So you have to stress using the same sequence in every patient for consistent. So you must be consistent, must be methodical in the way you do things so that don't forget other areas or to assess other areas. So the uterus and adenomyosis. So you must assess for the size of the uterus, the position of the uterus, the myometrium, the endometrium. So when you're checking for adenomyosis, check the size of the uterus. Is it enlarged? The normal size, the position, what the position of the uterus, then the myometrium, the heterogeneity, and other lesions that you can find there. Then also check the endometrium. How is it distorted? Is it normal position? Is it enlarged? So you have to look into all those aspects. So the sonographic signs of adenomyosis, so it's the heterogeneous myometrium, is asymmetrical wall thickening. You can have myometrial cyst, then you got fan-shaped shadowing, then you can have echogenic islands, then indistinct junctional zone, then the trans-lesional vascularity. So you can have trans-lesional vascularity. So these are the fundamental sonographic signs of adenomyosis. I have been showing you some signs of adenomyosis when we're doing our daily quiz sessions. I will also show you the images of how adenomyosis appears, like different types, different appearances. Then you appreciate that. I'll share that one with you in the other slide. So I am saying the sonographic sign of adenomyosis. Did you know about this? Heterogeneous myometrium, asymmetrical wall thickening, myometrial cyst, fan-shaped shadowing, echogenic islands, then indistinct junctional zone or the trans-lesional vascularity that should be present. Okay, so now we have to assess the ovaries, ovarian assessment. So this is still part of endometriosis mapping. So you have to evaluate the size of the ovaries, the mobility of the ovaries, the follicles, and the cysts. Evaluate the size of the ovaries, the mobility, the follicles, and the cyst. So the endometrioma features, so this is an endometrioma there. So it's a homogeneous low-level echoes, which is called the ground glass appearance that we're always supposed to see. Then with the thick holes, so the holes are thickened, as you can see there. With minimum internal vascularity, so there's no or internal minimum vascularity in the endometrioma itself. So bilateral in up to half of cases. So in most cases or some cases, it can present both ovaries. So you have to check both ovaries for sonography sign of endometriosis. There it is, right and the left side. So differentiate from hemorrhagic cyst, dermoid cyst, and the neoplasm. So you must pay due diligence so that you don't confuse them from a hemorrhagic cyst, a dermoid cyst, or a neoplasm. So be very careful when you're doing an assessment of the ovaries to check for endometriosis so that you don't confuse an endometrioma for a hemorrhagic cyst, a dermoid, or a neoplasm, which is the cancer of the ovary itself. So ovarian motility tests, ovarian motility sign, the kissing ovaries. What is called when you're saying that the kissing ovaries, saying that the ovaries they just get in contact with each other, so they're bigger. You say that they come into contact with each other. So the technique: apply gentle probe pressure, observe whether ovary moves freely, ovary is fixed, ovary adheres the uterus, ovary adheres the bowel. Fixed ovary suggests adhesions. Kissing ovaries strongly suggests severe endometriosis. So if you have got ovaries that are now enlarged, then they are non-mobile, then you should also think of endometriosis. So you must observe again the ovary. If it moves freely, ovary is it fixed? Ovary adheres to the uterus, or ovary adheres to the bowels. So fixed ovaries suggest adhesions. Kissing ovaries are strongly suggestive of severe endometriosis. Now let's talk about what's called the sliding sign. Do you know about the sliding sign, guys? Have you ever heard about the sliding sign? Do you also check on it when you are assessing for endometriosis? So the positive sliding sign structures they move freely. So the pelvic structures, the uterus, the ovaries, they have to move freely within the peritoneal space. So suggest no significant pouch of Douglas obliteration, no significant pouch of Douglas obliteration. So the negative slide sign, structure fails to slide. So suggests adhesions, obliterated pouch of Douglas, deep infiltrating endometriosis. So we are saying that when the adhesions, when the uterus, for instance, is attached by adhesions to the surrounding pelvic organs, it can't move because it's fixed, stuck. It's like a glue that is holding it in space, so it can't move. So a negative sliding sign is one of the signs that we use to say that there's endometriosis, or there's absent endometriosis. So you see, you have to make it a point that you're trying to use the sliding sign as much as possible to exclude endometriosis and also deep infiltrating endometriosis. So You also assess also the anterior compartment, So you have to evaluate the bladder wall, the vesicle uterine pouch, and the distal ureters when visible. So you have to check. They know this. There are nodules there. They have to check. You see, this is the wall of the bladder. There you can see there's a nodule there. So this is endometriosis. So this is deep infiltrating endometriosis. So you can see a nodule there on the base there. That's a nodule there, and the bladder is there. The sonography findings: hypoechoic nodules, irregular wall thickening, then reduced mobility, and then the focal tenderness. So these are the signs of deep infiltrating endometriosis. So you can see these hypoechoic nodules, they deposit there around the bladder, around the vesicle uterine pouch, and around the distal ureters. So be very vigilant when you assess for deep infiltrating endometriosis. So now you also have to assess the posterior compartment. The posterior compartments. What do you assess? You see these hypoechoic nodules that we have. These ones, they can be very silent. That you see those ones. It is very easy for you to miss endometriosis, deep infiltrating endometriosis, if you are not so diligent. You see how they appear. Like you see that one around the sigmoid colon there. You can see this area that is hypoechoic there, like a rim. It looks like a mass, like it is. There is a rectal sigmoid cancer there, but it's endometriosis. So assess uterosacral ligaments, the posterior vaginal fornix, the rectal vaginal septum, and the rectum, the sigmoid, and the sigmoid colon. So for those hypoechoic nodules, so the typical features of deep infiltrated endometriosis are solid hypoechoic nodules. They with irregular margins, then they can retraction, and then fibrosis, tenderness, and the distortion of the anatomy. So you can see that the anatomy will be distorted, and you are seeing these features. Then you should know that you are dealing with a case of endometriosis. So the features again: solid hypoechoic nodules. So you see, these are the solid hypoechoic nodules that I'm talking about. These are the solid hypoechoic nodules that you are seeing there. They've got irregular margins, so they're infiltrating, and retraction, fibrosis, tendon distortion of anatomy. So bowel endometriosis. So you can also see that endometriosis can infiltrate and affect the bowels. So you can see this deposits in the bowels there. They deposit in the bowels. So you can see on CT, there on MRI. Sorry, you can see endometriosis there. So the common site is the rectal sigmoid colon. That's where mostly you find deep infiltrating endometriosis. The entity will appear like that. So the sonographic features: hypoechoic muscularis lesion, hypoechoic muscularis lesion, irregular thickening with a narrowing of bowel lumen, and then reduced sliding. And then we can have fixed bowel loops. So the loops can also be fixed by the adhesions. So this is how you make an assessment of bowel endometriosis. So the measurements: you should record distance from the anal veg if assessed, then the lesion size, circumferential involvement, depth of invasion. So you know, once you're dealing with the bowel, so you must also assess the circumferential involvement. Is it occupying 1/3 of the bowel? Is it affecting 1/4 or the whole bowel? Is it encasing the whole bowel or not? So you have to report on those when you are doing endometriosis mapping. And the depth of invasion, how deep is it? You understand? So uh, initially I said you must also measure the distance from the anal veg. So from the anal veg there, you can then make a measurement to the exact spot where you see an endometric nodule. How far is it? So this is mapping, because we are localizing it. So this is the structured reporting. How do you report on endometriosis? So the suggested report format for you guys, I've just put this one suggest for you. Then you can also alter. This is just a template. So the clinician indication: pelvic pain, dysmenorrhea, infertility, then the uterus, the position, the size, adenomyosis, if it's there, they comment on it, the ovaries, the mobility, endometriosis, they are there, the adhesions, then you're checking on those. So the sliding sign, is it positive, is it negative? This is part of your report. Anterior compartment, talk about the bladder, the vesicular pouch, are they clear from these nodules or not? Then the posterior compartment, guys, you have to talk about check also the uterosacral ligaments and report on that, the rectovaginal septum, the rectum, the rectal sigmoid, and the sigmoid. So just make sure on the report that you're including those to make sure that it's mapped. This is a special type of a report. It's not the normal pelvic ultrasound report that you're talking about. We are now talking about endometriosis mapping. So the report of an endometrial map must show this, and the region that you didn't see, you have to indicate that I couldn't see the rectal sigmoid. I couldn't see the rectum. I couldn't see the sigmoid on ultrasound. You understand? You have to, so that the clinician will know which area has been mapped. If there's need for a CT MRI, you understand, then they can go for the MRI. So now, the conclusion: no evidence of dye, no evidence of deep infiltrated endometrium. If there is none, if it is there, then you have to report likewise. Mild disease, moderate disease, extensive disease with the bladder or bladder, bowel or bladder involvement. So you have to also then conclude, like, if it is is extensive, is affecting the bladder and the bowels. So you have to take note of that in the endometriosis mapping report, ultrasound report. There's a special type of a report. That's why I make this presentation. So now, the your key takeaways. So it has been a long presentation. So let me give you the key takeaways, and then you can call it home. You can call it a day. So remember these 5 key points. 1. Follow a systematic examination protocol every time. 2. Always evaluate ovarian mobility and the sliding sign. 3. Examine the anterior, middle, and posterior compartments. 4. Measure and document every lesion accurately. Then 5. Use a structured report to improve communication and surgical planning. Use a structured report to improve communication and surgical planning. So let me repeat the takeaways again. The takeaway points: follow a systematic examination protocol every time. Always evaluate ovarian mobility and the sliding side. Don't forget to examine the anterior, the middle, and the posterior compartment. If you don't, you have to tell the referring clinician that I couldn't do this. Then maybe there's a reason for that. Measure, document every lesion accurately and localize it. Use a structured report to improve communication and surgical planning. So don't just make a report haphazard. So with the structure of a format, you can have a template for endometriosis mapping. So those guys who are having maybe using their typing their reports, I urge you that you can make a template for endometriosis mapping, so that every time we're doing an endometriosis mapping, you just edit your report so that it conforms to a certain standard in their format. So this brings us to the end of this exciting presentation. Ladies and gentlemen, I thank you so much for your time, for your resilience, your patience. I encourage you to like and share our videos if you so do like them. Then I also need you to give us an honest feedback if there are areas of improvement or what else we could do differently for you to understand or to master what we are trying to put across. So there are practical sessions. If you are going to follow our practical cases, I'm going to be including the videos, upload some videos, so that you can also see how we do the practicals. Thank you so much. Enjoy the rest of your day ahead. Thank you.
Hello, colleagues. How are you doing? I hope that you are doing very well. So in this presentation, let us discuss about an intrauterine contraceptive device. So when someone is having an intrauterine contraceptive device and they start to have lower abdominal pain, the assumption is it could be the IUCD that is causing the pain. So at times, the IUCD will be very much innocent. So in this presentation, I need you to understand the role of ultrasound in evaluating patients with pelvic pain and an IUCD. So you should be in a position to recognize the normal sonographic appearance of an intrauterine contraceptive device. and then also differentiate IUCD related complications from unrelated pelvic pathology. You must also appreciate the importance of avoiding diagnostic bias. So, you don't just rush into conclusions to say. So, the history of this patient is a 32-year-old female. So, it's a para 2. So, she's complaining of severe lower abdominal pain for 5 days with intermittent pelvic cramps. Then she has mild spotting and pain worse during intercourse. She has no fever and no symptoms of urinary tract related. Then the copper IUCD was inserted 82 months earlier. So that's the brief history of the patient in question that we have today. So the initial suspicion from the referring clinician was that it could be an inflamed intrauterine contraceptive device, or is malpositioned, or probably it's just pelvic inflammatory disease, or an embedded IUCD. So the patient was requested for removal. She requested for removal of the IUCD because from the discussion they had with the doctor, she thought that that was could be the culprit. So on ultrasound, as you can see, I used trans abdominal. It was good enough, so I didn't have any need to show you the images that I later did, or to demonstrate the ovaries. So here you can clearly see, or here you can clearly see here the IUCD there. You can see it nicely there, and then you can appreciate that the surrounding areas, they are looking very okay. So the first thing that you're supposed to do is identify the uterus, then also the size, also the contour of the uterus. You have to make sure that the contour of the uterus is smooth and there are no other confoundings. So the uterus in this case looks homogeneous. There are no fibroids that I saw, definitely, and I didn't see any sonographic sign of adenomyosis. So the other thing that you're supposed to do is to assess the endometrium, then the fluid, if there are fluid anyway, or there are any retained products, endometrial masses. So those are some of the things that you ought to make peace with. So the assessment of the IUCD position is very pertinent, very critical. As you can see there, you must check for the fundal position, then the arms of the IUCD. So let me show you the arms of the IUCD, that they are fully extended. So then the stem is centered. So this is the stem. So these are the arms. So you can see these are the arms. Let me show you the arms. So what we have here, these are the arms of the IUCD. You can see they are well fully extended there. So that's the stem of the IUCD. So it should be centered. So you can see that it's symmetrical. It's centered in the endometrium, as you can appreciate there. So the entire device within the endometrium. So you can see that the entire device is located within the endometrial cavity, as you can appreciate there. So I can't see any sonographic evidence of embedment. So like this, look at this picture there. That one this one is embedded. That's an abnormally positioned intrauterine contraceptive device. So there's a difference. There's no sonographic sign of perforation, as I've seen from here. And also, I did not see any photograph sign of rotation or any migration, as you can appreciate from this echogenic IUCD. So on ultrasound, basically you have to understand the how it appear like. So it should be bright, as you can see, and echogenic stem. So on transversation, again, you must appreciate a small dot that is echogenic. So it should be symmetrically positioned, as I've alluded to. So you also have to demonstrate to show the cervix, and if there's nothing in the cervix as well, then if you can appreciate the ovaries, the normal follicles, the blood flow in the ovaries as well, if to check if there's no torsion, because if there's no pain, if there's pain, then you should consider other factors if the IUCD is in normal position. So you also have to assess the adnexia for possible masses that you can see in the adnexal regions. and no sonographic sign of tubal ovarian abscess. If there's any hydrosalpinx, ectopic pregnancies, is also you have to make peace with those. So you must also appreciate the back of the uterus, the part of Douglas, if there's no free flow in the POD or any complex collections, pass. So those are the things that you should look into. So in this case, or in my case, there was no evidence of an IUCD causing the symptoms whatsoever, unless maybe otherwise you saw them, but I tried my best, I couldn't. So now, what could be the differentials in case that the IUCD is in position, like in my case? So the differential can be early pelvic inflammatory disease that cannot be maybe not be so invisible on ultrasound, or ovulation pain, which is called mitochemes. Mitochemes can also cause pelvic discomfort of pain. So endometriosis can also be another factor. Then, unfortunately, from this video only on transabdominal, it could be difficult for you to visualize deep-seated endometriosis. Then you can also miss that one. So small hemorrhagic ovarian cyst can also cause abdominal pain or low abdominal pain. So gastrointestinal complications can also cause the pain. So in this case, that could possibly explain it, because you can see there's some bowel gas there. So this is some bowel gas that you can see here, which is casting this dead shadow there. So it could probably be due to bowel-related issues. So urinary tract pathology can also cause low abdominal pain, or it can be musculoskeletal related. So my advice to you, ladies and gentlemen, is you must avoid bias. So many clinicians immediately blame the IUCD for a crime that it never committed. So when a patient presents with pelvic pain, however, a normal IUCD does not immediately automatically mean it is responsible for the symptoms. So ultrasound, the role of ultrasound now in the evaluation of an IUCD should now evaluate the uterus, the ovaries, the adnexia, the cervix, the cul-de-sac, and the urinary bladder for any other pathology that might be causing the problem before concluding that the IUCD is the cause. So in general, we should not always blame things. You must also look at the merits of certain things. So the IUCD is one of the safest long-acting reversible contraceptive method. So if it is correctly positioned, like in this case, it really causes severe pain after the initial insertion period. It can cause persistent pain, usually suggests another pelvic pathology. So if you see that there's persistent pain, it could be something else. It could also be the one causing the infection. So it can be rejected by the body. So those are some of the things that you have to make peace with and understand when you are assessing the PID. So ultrasound plays a crucial role in confirming correct placement and also including complications. So you must know that when these patients comes to your department, the ultrasound that you're using is very valuable in the assessment of an IUCD. So some of the complications that arise from the insertion of an IUCD can be malpositioning, that's I've discussed about, which is or a low-lying IUCD, then impediment arm within the myometrium, like what you saw in this image there. So it's embedded there, and also perforation. You can also perforate and it go outside there, the mass of the myometrium of the uterus. So and it can also be expelled via the cervix expulsion. Then it can also cause pelvic inflammatory disease. So that will be PID. So thickened uterus, free fluid, and hyperemia are associated with pelvic inflammatory disease, or the infection that can be induced by these IUCDs. So pregnancy, gestational sick despite IUCD. So these are some of the challenges that someone can still get pregnant despite them having the IUCD. So those are some of the challenges. So now when you're writing the report, you must indicate that there's no sonographic evidence of malpositioning, impediment, perforation, inflammation, or pelvic inflammatory disease. So those ones you should always write them in your report. So now the learning points in this case are always assess IUCD location systematically. So you have this systematic way of doing things, and just not blaming the IUCD for crimes that it never committed. So a normal position IUCD is unlikely to be the cause of chronic pain, and ultrasound should exclude the alternative causes before recommending IUCD removal. So you must also correlate imaging findings with the clinical examination laboratory results. You must avoid bias, so do not attribute symptoms to the IUCD without objective evidence. So we need objective evidence before we can say that the IUCD is the culprit or the cause of pain that the patient will be experiencing. So I think this is making a lot of sense. So I really had to include this case under my discussion because it's not always the case that if there's pain, it is always attributed to an intrauterine contraceptive device. But the knowledge and the history that for you that know that it is there gives us a lot of leeways to navigate through. So we are navigating from multiple angles to see, is it the cause? Can it be the culprit, or it's not, or something else? So, ladies and gentlemen, next time when you are seeing a patient with an intrauterine contractures, don't exclusively exclude that as the cause of pain. It could be, in most cases, could be the cause of pain, malpositioning, inflammation that are induced by these IUCDs. So I thank you so much for your time. I hope you are learning, and I also appreciate your presence in the channel. I also take your comments seriously. Please do give us constructive criticism so that we grow. We also reach the bigger audience. We need a bigger international audience that is coming to harmonize our practice, to improve our practice. Also, we need to learn from them. Thank you very much. Enjoy the rest of your day.
Welcome, colleagues. So in this presentation, I am going to discuss about what is called the misleading shadows. So when you're doing your ultrasound, there is what we call the misleading shadows. Have you ever heard about the misleading shadows? Or it's your first time? If it's your first time, I am going to take you through. I need you to listen and you get to appreciate and understand what these misleading shadows are when you're doing an ultrasound scan and the illusions that arise because of the misleading shadows. So differentiating solid ovarian masses from penile fibroids with Doppler. So a comprehensive ultrasound presentation for sonographers, radiologists, and gynecologists. This is quite comprehensive, ladies and gentlemen. Quite comprehensive. So I need you to listen till the very end. Do not miss any portion of this presentation, please. Otherwise, you are going to have a problem with your diagnosis and giving misrepresentations. So now, the misleading shadows. Differentiating solid masses from penile fibro using color Doppler. So you can see this is color Doppler. You already know color Doppler and how to use it. I hope so. If not, I am sorry. I need you to work on that. So you can see the uterus there, the ovaries there. So this is a B mode, then color Doppler. So by the end of this presentation, participants should be able to understand why penile fibroids mimic ovarian tumors. You must understand the difference there. So identify grayscale clues, use Doppler correctly, and then you must recognize the bridging vessel sign and also apply a systematic diagnostic approach and avoid unnecessary surgery. So, if you are going to write these dubious reports, it will lead to a lot of unnecessary surgeries, which are not called for. So, a penile fibroid, subserosal fibroid, projects away from the uterus. I hope you know I've explained about the different types of fibroids before, but it's the one that projects away from the uterus. So sometimes the connecting stalk is extremely thin. The ipsilateral ovary cannot be identified. The lesion lies within the adnexia. So at times the penile fibroid can mask or obscure this ovary which is on its side, and it becomes very difficult to visualize. So the examiner might therefore conclude that a solid is a solid ovarian mass. Because it's obscured, you can't see it because of the pedunculated fibroid. So you think that the fibroid itself is an ovarian mass instead of pedunculated uterine fibroid. So this mistake can completely alter the patient management. It really alters the management of the patient. So now, what are the clinical consequences of this mishap? So misdiagnosis may lead to unnecessary referral to a gynecological oncology, anxiety regarding ovarian cancer, expensive MRI examinations, incorrect surgical planning, oophorectomy instead of myomectomy. So you see now how a misdiagnosis can cause mismanagement of the patient or the extra expenses which are not necessary for the patient. So let me briefly take you again down the lane of our pelvic anatomy. So this is just a brief overview. So here with the urinary bladder there, then with the uterus there, the ovaries there on either side, the right and the left side ovary there. So that's the same anatomical diagram there. This is a transmural fibroid. You can find it there. Then you can have the subserosal fibroids there. Then you can have an intramural fibroid there. Then you've got the submucosal fibroid which are here. Then you've got the intramural fibroid. Then you see now what we have is a pedunculated fibroid. So this is a pedunculated subserosal. We can also have a pedunculated submucosal fibroid, which is inside the endometrial cavity. But this one is a pedunculated subserosal, it's outside. So now you must understand where the structures originate. That's the very basic and very fundamental attribute that you must have. You must understand where anatomy or structures are originating from. If it is a pathology, where is it coming from or originating from? So the uterus, the central pelvic organ, continuous with the cervix, is surrounded by the myometrium and the ovary. They are mobile, connected by ovarian ligament, and they contain the follicles. They contain the follicles. So now, the pedunculated fibroid originates from outer myometrium. So it originates from out of the myometrium, so here, like that. So remains attached to the uterus by a stalk. It simply extends towards the adnexia. So it's extending outside the uterus toward the adnexia. So the problem, it has got a stalk, so it can twist and cause a lot of pain, a pedunculated fibroid. So why fibroids mimic ovarian tumors? Why do you know why fibroids? Do you know why fibroids mimic ovarian tumors? So several reasons explain the confusion. So let me highlight the major ones. Is the larger size. So large fibroids distort the pelvic anatomy. They will distort the pelvic anatomy, then you can mislead them for ovarian tumors. Thin stalk, the uterine attachment may be invisible. You might not see the connection with the uterus. Degeneration also can be another causative factor. So fibroids become heterogeneous. Calcification so produces dense shadows and then cause the confusion. Ovary not visualized. So the normal ovary may hide behind the lesion. So you can have a superimposition where the ovary itself is hiding from it's being masked by the pedunculated fibroid. Then you can miss it easily. So the common solid ovarian masses. These are the common solid ovarian masses. So there's a ovary there. Then you can see there's an ovarian mass there, which is a fibroma. Then you've got a fibroma there. There's another mass there, another mass there. So major differential diagnoses include, these are the differentials for a pedunculated fibroid. The ones which are benign, we with a fibroma, we with a fibrothecoma, we with a Brenner's tumor, we also with the mature cystic teratomas. So these are differentials to a pedunculated fibroid. So at times it becomes very difficult for you to say, is it a pedunculated fibroid or is it the differentials? So malignant, so epithelial ovarian carcinoma, dysgeminomas, the metastasis. So these are the malignant lesions of the ovary that can also masquerade as pedunculated fibroids. So the grayscale features of a pedunculated fibroid. These are the features that you must master back to back. So you see here, you have got a uterus there with a stalk, and then you've got a pendulated fibroid there, and you can see here there's a calcification that we have in this fibroid, and then you can see here this is the degeneration. So there's a central cystic degeneration of the fibroid there. So the typical appearance of a pendulated fibroid, the shape is round or it can be oval. It can be well defined. It's not sequential, so it has to be well defined. So the echogenicity of a pendulated fibroid, it's usually hypoechoic and sometimes heterogeneous. So you can see here it's hypoechoic and it can be heterogeneous there with mixed of components, mixed portions, like that. So the margins, they are mostly very smooth and well circumscribed. So you can see the margins are well circumscribed and very smooth like that. Okay. Then the posterior shadowing. So very common, especially when fibrous and calcified. So you can also have like this. You can see there is posterior acoustic shadows because of the calcifications in the fibrous tissue of the fibroid itself. So those things can now also mislead you to think of a malignant transformation, because malignant tumors also, they tend to have posterior acoustic shadows. So you can see here, that's degeneration now. So produces cystic spaces, mixed echogenicity, and irregular appearance. So those are the other features or other attributes of a penangular fibroid. So they are variable depending on the maturity, the stage, the feeding that is getting. Understand, if it's getting enough blood supply, if it's not getting enough blood supply, start to degenerate, then you can have central cystic spaces like that. So grayscale features of solid ovarian tumors. So now I was talking about the grayscale sonographic sign of a penangular fibroid. Now let's talk about the grayscale for the ovarian tumors. Typical findings include ovarian origin, irregular margins sometimes, then it can have internal vascular tissue and papillary projections, ascites, malignant. So if it's a malignant or a cancerous ovarian mass, is mostly associated with ascites or fluid in the peritoneal space. That's the malignant ascites. So virality, so it can affect both sides. Complex cystic solid pattern, unlike fibroids, ovarian tumors usually replace the ovarian tissue. So they normally replace the ovarian tissue because they are originating from the ovaries. So step one, what you're supposed to do when you're doing an ultrasound scan to identify these subtle or these confusing lesions, you must find both ovaries. One of the biggest mistakes is stopping after finding the mass. So if you see a mass, don't stop there. You must identify the fibroid. Otherwise, you're going to mistake the origin. Is it originating from the uterus? Is it originating from the ovary itself? So that can be a bit confusing. Always ask, can I identify both ovaries separately? That's a question that you are asking yourself as you are doing the sonar. So the certain questions you have to ask yourself, not necessarily the patient, but the patient doesn't see the internal structures. You understand? You are the one asking yourself. If the ipsilateral ovary is seen separately, so the word ipsilateral means is in the same side. So you can have a mass, then check on that side if there is an independent or separate ovary. So the lesion is unlikely to originate from the ovary. This single observation often solves the case. So if you know if the lesion is originating from the ovary or is not, that can solve the puzzle. So the bridging vessel sign. So guys, ladies and gentlemen, you must write this down. Write this down. The bridging vessel sign. The bridging vessel sign. So most important Doppler sign. Color Doppler demonstrate vessels running from the uterine myometrium directly into the mass. These vessels form the bridging vessel sign. So you can see if you have got a vessel that is coming from the myometrium, then going to the to feed the mass. That is what we call the bridging vessel sign. So you can see the vessel there. That's the bridge there. That's the bridging vessel. Why it matters? Why it matters? It confirms uterine origin, not ovarian origin. So if you see a bridging vessel that is coming from the myometrium and feeding the lesion, then you must be convinced that this lesion is originating from the uterus, not the ovary cell. So the bridging vessel sign is very critical for us to identify and differentiate the origin of a lesion, ovarian or uterine. So the Doppler characteristics. So the penile fibroid, it has got peripheral vessels, low vascularity, bridging vessels, peripheral circumferential flow, and minimum internal flow. Whereas an ovarian tumor, it has got random internal vascularity, it has got central flow, chaotic branching, multiple penetrating vessels, not a bridging vessel, hypervascular malignant tissue. So it has got hypervascular if the lesion is malignant, is cancerous. So you can see the differentiation, the Doppler characteristics. So peripheral vessels, low vascularity, the bridging vessels, peripheral circumferential flow, minimum internal flow. So the ovarian tumor, random internal vascularity, central flow, chaotic branching, multiple penetrating vessels, and hypervascular malignant tissue. So, ladies and gentlemen, you must appreciate this. The value or the role of Doppler imaging to differentiate the origin of the masses. So this is very, very critical, so that those shadows cannot confuse you. You cannot be confused by the shadows, which is which. So the power Doppler is more sensitive than color Doppler. Useful when blood flow is slow, fibroid stalk vessels are tiny, conventional Doppler appears negative. Power Doppler frequently reveals the vascular pedicel. You can imagine how powerful the power Doppler can be and how useful it can be in order to localize the origin of an ovarian or a uterine lesion. So it can differentiate, it can localize. Power Doppler is very magical when it comes to these masses. So you must have an interplay of all the types of Dopplers for you to get the answer. The spectral Doppler, pediculated fibers usually demonstrate higher resistant flow, moderate vascularity. Ovarian malignans often show lower resistant flow, greater neovascularity. Spectral Doppler supports the diagnosis but should not be used in isolation. So we are saying that in as much as we are saying that penangulated fibroids usually have with a high resistant flow and a moderate vascularity, and the ovarian malignancy have with a lower resistance and greater neovascularity, we must not just use spectral Doppler in isolation. So it must combine with the other features, the B mode findings and the power Doppler findings. You must correlate all those things to come up with a comprehensive and very correct diagnosis. So the comparison table, the feature penangulated fibroid, ovarian mass. So the origin, uterus or ovary. The bridging vessels, they are present or absent. The separate ovary, usually visible, not separate. So posterior shadow for penangulated side is common, whereas in solid ovarian mass is less common. Peripheral flow is common in a penangulated fibroid, whereas solid masses is variable. Central vascularity minimum, often marked. Calcification frequent, less common. Mobility moves with uterus, it's independent. So you can see now how you can differentiate a penangulated fibroid from a solid ovarian mass. Let me repeat again the origin. This one from the uterus, this one is from the ovary. Bridging vessels, they are present in a penangulated fibroid, they are absent in ovarian mass. Separate ovary, usually visible, not visible, because this is when it's originated from the ovary cell. Posterior shadow is common in penangulated fibroid, where it's less common in ovarian mass. Peripheral flow is common in a penangulated fibroid, yet is variable in a solid mass. Central vascularity is minimum in a penangulated fibroid, whereas often marked in an ovarian mass. Calcification, they are often frequent in a penangulated fibroid, whereas less common in ovarian mass. Mobility moves with the uterus, the penangulated fibroid, whereas the solid ovarian mass is independent of the motion of the uterus. So what are the common pitfalls, ladies and gentlemen? What are the common pitfalls? What are the common pitfalls? Do not rely on the size, the echogenicity, the location. Do not rely on size, echogenicity, and the location. So the pitfalls include degenerating fibroid, broader ligament fibroid, large ovarian fibroma, pregnancy, obesity, poor bladder filling. These are the common pitfalls. So we are saying the location on its own is not enough to say that this is coming from the ovar or uterus. The echogenicity on its own cannot be used to differentiate or to localize the origin of a mass. The location itself, it can go anywhere, but with where it is attached to the uterus, for instance. So the pitfalls include degenerative fibroid, broader ligament fibroid, large ovarian fibroma, a pregnancy, obesity, poor bladder filling. So examination technique now, use trans-abdominal scan, then transvaginal. So you have to start from the trans-abdominal, then you do the transvaginal scan. Evaluate both ovaries, uterine contour, the cervix, the cul-de-sac, color Doppler, power Doppler. Sweep through the entire pelvis. Never evaluate one image. Never evaluate on one image. This is your Bible. Take note of that and write it down. Never evaluate one image. Evaluate multiple images in different planes, in dynamic and static views. So when now does MRI help? When now does MRI help to differentiate these pedunculated fibroids from ovarian mass origins? So MRI is recommended when ovaries cannot be identified, Doppler findings are inconclusive, massive degeneration obscures the morphology, and then surgical planning is required. So those people now that when we need to plan for the surgical management, then they have to use MRI or when you want to embolize, embolization, you also have to consider using MRI instead of X-ray. So you can see the peduncular fibroid on MRI there. So you can see the peduncular fibroid on MRI there. So MRI clearly demonstrates the uterine attachment, the stalk tissue composition in ovarian anatomy. So those are the major advantages, the merits of using MRI over ultrasound. So you must write this down and understand everything for you to master differentiating the origin of pelvic lesions or masses. So now, here I have given you a symbol suggested report. How do you write the report? So this is a simple report that you can use, a template that you can use. So finding solid hypoechoic adnexal mass measuring that much centimeters. So the bridging vessels are demonstrated extending from the uterine myometrium into the lesion. Both ovaries are identified separately and appear normal. No papillary projections or ascites noted. The impression findings are most consistent with the pedunculated subserosal uterine leiomyoma rather than an ovarian neoplasm. Ladies and gentlemen, this is a report that looks like any other, but it's not a typical report that you know of, because this is a detailed report that is capturing the differences between a mass of ovarian origin and a mass originating from the uterus. Let me read the template for you again. Before you take these notes, please write your own template or save this template, please. You can simply screenshot it from your screen like that, stop the video, screenshot it, the template, then you can edit it, or you can just write it down and then have it as part of your armamentary of ultrasound. So, solid hypoechoic adnexal mass measuring that much centimeters. Bridging vessels are demonstrated extending from the uterine myometrium into the lesion. Both ovaries are identified separately and appear normal. No papillary projections or ascites. Bridging vessels are demonstrated extending from the uterine myometrium into the lesion. These are the key words, guys. These are the key words. Please, 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 please understand this. The bridging vessels, they show that it's a peduncular fibroid. So the impression findings are most consistent with a pedunculated subserosal uterine leiomyoma rather than in ovarian neoplasm. So now, what are the key take-home messages? Always identify both ovaries. Look carefully for the uterine stalk. Search specifically for the bridging vessel sign. Use both color and power Doppler. Correlate grayscale findings with vascular patterns. MRI is valuable when ultrasound remains indeterminate. So these are your take-home messages. Please, these are for you. Always identify both ovaries. Look carefully for the uterine stalk. Search specifically for the bridging vessel sign. Use both color and power Doppler. Correlate grayscale findings with vascular patterns. MRI is valuable when ultrasound remains indeterminate. So now, let's have an algorithm. This is an algorithm. This is a chart. You must have this also in your room, guys. This chart helps you to make the workflow of assessing these pelvic masses or lesions very easy. So, solid adnexal mass. Can both ovaries be identified? Yes. If no, consider ependycular fibroid. Use color Doppler. Bridging vessels present? Yes. Ependycular fibroid. No. Assess ovarian vascularity and morphology. Subspecies features? Yes or no? If yes, ovarian neoplasm. MRI or gynecology referral. If no, indeterminate, then use MRI. This algorithm is very, very critical. Solid adnexal mass. Can both ovaries be identified? So you're asking yourself the questions and answering them. Yes or no? Yes or no? If the both ovaries can be identified, then consider it a ependycular fibroid. If not, use color Doppler. Bridging vessels present? Is it no? If yes, it's a ependycular fibroid. If no, assess ovarian vascularity and morphology. Assess ovarian vascularity and morphology. Are there any suspicious features? Yes. Then ovarian neoplasm, MRI or gynecology referral. If no, then indeterminate, then go for an MRI. Ladies and gentlemen, these are the practical pills. These are the final practical pills for this presentation. The bridging vessel sign is the simple, single, most helpful Doppler feature for establishing a uterine origin. The bridging vessel sign is the single most helpful Doppler feature for establishing uterine origin. Seeing a normal ovary separated from the mass strongly favors a ependycular fibroid. Central chaotic vascularity, papillary projections, ascites, and inability to identify normal ovarian tissue increase concern for an ovarian neoplasm. Always combine grayscale morphology, Doppler assessment, and systematic pelvic survey rather than rely on imaging feature alone. Ladies and gentlemen, this brings us to the end of this presentation. This is advanced ultrasound. It's no longer the ultrasound where you just say, rush, say it's a mass, write the report, send the patient away. This is a characteristic masterclass ultrasound piece of a lecture where we are going into the depth of ovarian masses, how to differentiate them, so that we don't cause unnecessary panic, we don't cause unnecessary expenses, we also don't have to cause unnecessary complications to the patients. Ladies and gentlemen, I thank you so much. Don't forget to comment, like, and share our educational content. Let's meet again in the next episode. Thank you.
Hello, good people. How are you doing? So the case that I have today will shock you. It's one of those things that are very rare. So I need you to watch until the end of this video and you can see the shocking findings. I hope and I wish that this will shock you as I was shocked also because it's my first time, and I hope most of you it's also will be your first time to see this type of a pathology. So the first thing that is a transvaginal ultrasound. So you can see here there's a fibroid. This is not the shocking thing. So this is a nice subserosal fibroid there. This is the subserosal fibroid there. You can see this peripheral vascularity. That's our
our uterus there. You can see the blood vessels there. That's the bladder there is fine. So the fibroid is here. That's a well outlined fibroid there. Well outlined fibroid there. Well outlined fibroid there. So you can see this one microvascular flow. There you can see the so it's there's no color flow inside. You can see the cervix here nicely. The cervix here nicely. There is the thing that I'm talking about. You can see this is a vaginal wall mass. This so there's got the honeycomb structure. You can see this. So what do you think this is, guys? This one, this lesion there. What is this? That's just adjacent to the vagina there, on the vaginal wall. There we have it. You can see it with cystic components. It has got cystic areas like that. What do you think this thing is? What is this? So let's do it together. This mass with the honeycomb structure, mixed solid, and cystic portions like that. What is that? What is that? What do you think that thing is? What is that? So I need you to brainstorm on it. Me, I'm still shocked. I am very much shocked what that thing is. But let me say my thinking in this case. I am thinking of a high density cyst. So a vaginal high density is very rare, but the morphology of that mass now it is called the morphology of an echinococcus cyst, high density cyst. The side structure that you've seen there. So you can see here. That's my thinking, my line of thinking that this is a vaginal echinococcus cyst, but it's a very rare finding, if not one of its own, if not one of its own. So I hope you are also giving you differentials. If you think otherwise, I need you please to send your results on the comment section to say that I think this is what this thing could be. What do you think that is? What do you think that is? Mostly these identity cysts they do happen inside the liver. That's the most common site for echinococcosis or echinococcosis. But in this case now, it's my first time to see a high density cyst that is manifesting itself in the vagina. So the referring clinician was saying that there is a mass in the urethral mass, but it is not in the urethra or on ultrasound as you have seen. So give me your suggestions. I also need a pool of differentials. What can this be? What can that be? What can that be? What can that be? Initially, I thought it is bowel, but there's no bowel motion, as you can see. The fluid is the only one that is moving a bit. So, what's your take on this, mass? What's your take? What's your take? So, let's talk, guys. Let's discuss. I need also your assistance. I might be wrong, but my thinking is that this is an echinococcal cyst, a vaginal high density cyst. So, it's a very rare manifestation. So, I think I'm one of those blessed to have witnessed it during my time of practice. So I just saw it today, just now. So I decided to upload this video because it's one of those most interesting cases. So, but I need your take. I can't be alone in this race, guys. Don't leave me alone. Let's go together. Let's fail together. Let's fail together. Uh, yeah, this was a straightforward diagnosis. Yeah, this was a straightforward diagnosis. Do you know what? Yesterday I did the same patient, a transabdominal sonar. I just reported on the serosal fibroid, but I couldn't pick this one from a trans. So now the mass is presenting low. The doctor sent the patient back. So now we are seeing this one. You see, it's more here, it's more here. So what's your take? What's your take? What's your take? What's your take? Help me, guys. I am also stuck. I am also stuck. But there's no flow, you know. There's some internal or Rolex formation. There's some movement there. This is the kinetic energy from the probes, you know, that these particles are now moving inside this, but they are not blood vessels. So let's do it together under the comment section. Give me your thoughts. Thank you so much. Don't forget to subscribe and share. Also give your comments and let's talk.